I'm Dun Jack Fu, or DJ Fu. I'm a ophthalmology clinician and researcher based in London, Moorfields Eye Hospital and King's College, London. So the two things I came here to present were primarily our workflows on the phase 3 trials OAKS and Derby, so pegcetacoplan versus sham in geographic atrophy over 24 months. The two pieces of work that we were presenting was, number one, how we evaluate treatment outcomes. So traditionally, you would measure how much GA there is, and they reported that using autofluorescence imaging. So one modality, very accepted, but what we see a lot more in the world and more accessible is OCT imaging. And there's a lot more on OCT imaging that can, there's a lot more GA features that are captured by OCT that autofluorescence just doesn't see. For example, photoreceptor degeneration, right? We know photoreceptors are really, really important. They're important for vision. They're an important component of GA disease, but it's something that you would only really see on OCT. Now, manually segmenting and quantifying this is just not feasible. So we've previously already developed, validated, published a model that automatically segments, quantifies each of the constituent features of geographic atrophy automatically. And in that sense, it's great to have huge data sets because then it's not an issue when you have such an automated workflow. And then we could look at, well, how does it perform not just on autofluorescence geographic atrophy, but then also each of the OCT biomarkers. So photoreceptor degeneration, RPE loss, hypertransmission defects, and RP and outer retinal atrophy, or RORA. So what does the treatment do over time? Well, we see that no matter what, whether you receive sham or treatment, you're going to have more photoreceptor degeneration and RPE loss over time. But if you were in the treatment arms receiving the drug, that went slower. So it looks like the drug slows down both photoreceptor degeneration and RPE loss over 24 months. It's about 30%, so a statistically significant difference of 30%. What does that actually mean? Well, for RPE loss, that was about 1 millimeter squared. 1 millimeter squared is about 3,000 to 4,000 RPE cells. That's about one fovea worth, right? So over 24 months, if I can spare an entire fovea worth of RPE cells and 10 times that of photoreceptors, that sounds like that some people might be interested in. We also looked at photoreceptor degeneration and isolation. So that's a separate biomarker that we've published on. It's an independent predictor of how much you're going to have, how much GA growth you're going to have in the future. So if you have a lot of photoreceptor degeneration and isolation at baseline, in the future, you're just going to have more. And we essentially use that to show that the drug doesn't have an equal effect on photoreceptor degeneration and RPE cells. It looks like the drug, pegcetacoplan, seems to protect photoreceptors more so than RPE cells, which is quite interesting because there's a bit of controversy of where complement inhibition actually works in the entire pathway, right? So if you subscribe to the paradigm that photoreceptors are affected first prior to RPE loss, then that would suggest that it works a little bit higher. But just, I'll leave the controversy there and I won't go further than that. Apart from that, so apart from then saying, okay, well, here's some OCT biomarkers and we see this difference, that's only really cool if there's a functional significance, okay? So that it's only cool if that means something to a patient or to a clinician who would then change a management plan. And so the next piece of work we did was we said, well, to what extent do these OCT biomarkers actually correlate with functional significance or a function? We've previously shown that it correlates with best corrected visual acuity, but best corrected visual acuity only really relies on the central bit. And we know that you can have GA without it affecting the central bit. That's 80% of patients. And so you can have, most people will have GA and they won't have best corrected visual acuity affected. So what do you do instead? We looked at microperimetry. So systematically, spatially mapping out retinal sensitivity across the macula. At a single point of the macula, how sensitive is that piece to light? And then we use our algorithm on top of that to see, well, was there any geographic atrophy at all? And what we showed in the second piece of work is that, yes, we see a very high correlation between how much of these OCT biomarkers of geographic atrophy and retinal sensitivity. That's true at a given time point. So if I take your OCT and then I take your microperimetry at that same day, you have a pretty accurate mapping, which is okay. I could also just ask you to do the test. But what seemed to be more important was that it was more predictive than conventional imaging like autofluorescence. And also we had longitudinal data. We could see that. We could predict which points over the next 24 months were going to become scotomas, right? No sensitivity. Sensitivity is 0. So yeah, those are the two pieces of work. And I guess what we're interested in is now the following step, which is figuring out whether if you had treatment effect on the biomarkers, and I'm saying the biomarkers have visual and functional significance, can I just actually see whether there's a treatment effect on microperimetry, and that's going to be the next step.
When pegcetacoplan was first introduced, it was targeting late-stage AMD with geographic atrophy. Lately, there have been ads as well as patients who have said that their ophthalmologist suggests the drug be used earlier on in macular degeneration. Is that something that is recommended now?
I'm UK-based, and I've had the privilege to look at the data, and much like many people, I think one of my main messages is that it's just very, in the UK, and I think actually just as a value proposition to any patients, you can only suggest a certain treatment when you have a greater benefit than the risk, right? And on the microperimetry part, we still need to do the analysis to show that, I think. So that evidence isn't quite there yet. And if you were looking at the foveal protection bit, whilst it makes a lot of sense, like I think theoretically it makes a lot of sense that, well, what if I start treating with people who don't yet have foveal involvement, so earlier and thus protecting it? I think the evidence points towards that that's the case, but I can't tell the future. You know, I think we're frequently been wrong with things that make sense, and then you do the experiments, and it's just not quite there. And at least for the UK, we don't really recommend. I think it's difficult for them to recommend treatments without that key bit of evidence to then see. Well, at least what we need to see is we need to see a subgroup, that subgroup of people who are that much earlier, who then start treatment compared to those who don't receive treatment, and then see whether they preserve that vision. I mean, if you asked me to gamble, I would probably gamble that was the case, but for clinical decisions, I don't do that.
Is there anything you'd like to close with?
I understand why autofluorescence was used as a clinical endpoint, as the primary clinical endpoint, and that has brought us this far because that was attainable. It's what we had, and it seemed very representative. But I think with some of this work here is we're actually in a gray zone now because we've been using autofluorescence. It's not entirely clear how early or how we treat or who we should treat, and I think that's because it doesn't capture the full picture of geographic atrophy, and I think if we're going to go more structural, we should go with OCT, right? OCT should be, and its features should be informing the clinical endpoints, because we're showing, or at least even just I have shown, and other people have shown independently as well, that OCT to a greater degree represents the anatomical stages of GA disease, as well as what's functionally going on. And if you just compare that to autofluorescence, what we had before, it does it better than that. And then that's how science works, right? We have something better, and then we move towards that, and then we get more and more a clearer image of the picture. Yes, if I were to boil it down, I would say autofluorescence alone is not enough because we have these other tools. It would be great to then include OCT. If you maybe choose between the two, there's a clear winner, and that's OCT. And sometimes we have to choose between two things. So I don't see at this point why we're not overusing OCT. And if we needed a functional measure, best corrected visual acuity, of course we should record that. And we should also be considering microperimetry. If you maybe choose between the two, again, the same exercise, I would choose microperimetry.
Thank you for sharing your time and your research with us today.